if you remember from the previous lecture, we studied 4 main histologic types of lung cancer. And sooner or later, all these types may progress into metastasis. And lymph nodes are considered a common site for metastasis, so they may spread and involve lymph nodes, including lymph nodes in the carina, mediastinum, the neck, and the clavicular region. Now, the involvement of some lymph nodes is considered characteristic, and this is including the left supraclavicular lymph node, or it's called also virchow node. Virchow node أو left supraclavicular lymph node هي lymph node موجودة in this soft tissue area in this triangle. The enlargement of this lymph node sometimes can be characteristic of the presence of an occult tumor, يعني tumor غير مشخص. The most common tumors that may involve the virchow lymph nodes are lung cancer and gastric cancer. So sometimes this is the first presentation in those patients. As I told you, this disease can become advanced and spread to the lymph nodes, and also it may cause distant metastasis. So it may involve the pleural or pericardial space, and this will result in inflammation, pericardial or pleural effusion. The tumor may grow large, causing compression or infiltration of the superior vena cava. And as you may know, the superior vena cava drains blood from the upper parts of the body into the heart. So compression or infiltration of the superior vena cava may result in something called superior vena cava syndrome, where the patient will present to you with shortness of breath, with difficult swallowing and congestion of the blood vessels. Now sometimes the tumor, whatever the histologic type, may involve the lung apex, the most superior part of the lung. And this will result sometimes in infiltration of the brachial and the cervical sympathetic plexus. So the apical tumors is called Pancoast tumor. And if it causes infiltration لا brachial or the cervical sympathetic plexus, بنقول إن التيومر عمل إشي اسمه Pancoast tumor, Pancoast syndrome, sorry. So the Pancoast syndrome is characterized by the presence of severe pain, especially in the distribution of the ulnar nerve. كلكم بتعرفوا the distribution of the ulnar nerve. And also it may cause Horner syndrome. في حدا بيعرف شو هو Horner syndrome? It results from the involvement of the sympathetic nerve plexus. فالمريض رح يجي بإبسيلاترال يعني على نفس الجهة. رح يكون عنده enophthalmos, which is the posterior displacement of the eye, ptosis, which is a dropping eyelid, and meiosis, reduction in the size of the pupil, and hydrosis, loss of the sweating on the same side. Sometimes the tumor may cause destruction of the first and second rib, and sometimes it may extend to involve the thoracic vertebra. So Pancoast tumor may result in Pancoast syndrome. As other tumors in the body, we tend to stage those tumors to determine the treatment and the prognosis for your patient. And we use the TNM staging system. The T stands for the size of the primary tumor. N stands for the regional lymph nodes. So you need to know how many lymph nodes are involved and which type of lymph nodes. Yani you need to name them. And metastasis, the presence of distant metastasis. According to the TNM stage of this tumor, the management plan and the prognosis can be determined. Clinically, this is considered the most insidious and aggressive neoplasm, but the patient is mostly silent because the tumor must grow into a certain size to produce symptoms. If the tumor grows large, the patient may present with respiratory symptoms that are related to the lung involvement itself, like cough in 75% of cases, weight loss in 40%, chest pain in 40%, and shortness of breath in about 20%. But sometimes the initial presentation can be an initial presentation of metastasis, involvement of other organs. So the patient may come with hoarseness of voice, which results from the involvement of recurrent laryngeal nerve, or superior vena cava syndrome when the tumor infiltrates the superior vena cava, or pericardial and pleural effusion, and this is like considered metastasis. Or sometimes the tumor will grow large, فبصير large in size to cause resorption atelectasis, and sometimes superimposed infection resulting in pneumonia. Sometimes the initial presentation of lung cancer can be with symptoms and signs related to metastasis. يعني lung involvement and even the lymph node involvement were not the initial presentation. While the invasion of adjacent structures, the distant metastasis can be the first symptom. Like when the brain is involved, which is a common site for metastasis of lung cancer, this may result in mass effect, mental or neurologic change. فبتلاقي المريض صار في عنده change في البيهيفير، change بالاتيتيود، المريض بيتغير طريقته، يعني انت بتحس انه هذا الشخص صار another personality. Sometimes this may indicate disease in the brain سواء كان primary أو secondary، سواء كانت infection أو tumor, so you need to investigate the patient. The liver can be involved and this may result in hepatomegaly. Bone can be involved and this may result in bone pain. The adrenal gland also is a common site for metastasis بالنسبة لللung cancer. بس adrenal insufficiency is not common في الناس اللي عندهم lung cancer. السبب انه لازم يكون في عنا loss لكمية كبيرة من الcortical cells in the adrenal عشان يصير في عنا adrenal insufficiency أو Addison disease. لكن في حالات اللنج كانسر still بيضل عنا reserve cell من الكورتيكال cells اللي بيكفوا حتى يعملوا الفانكشن. In terms of a prognosis, in all the histologic types and despite the systemic therapy, chemotherapy, the surgery, the radiotherapy, the prognosis is still poor. So the prognosis is poor in all types of cancer, of lung cancer, because the overall 5-year survival rate does not exceed 19%. It's about 18.7%. And this is is affected by the stage of the tumor. So if the tumor is localized, then it's about 52%. But if the tumor extends to involve the regional lymph nodes, this accounts for 22% the 5-year survival for the patient, and only 4% if the patient have distant metastasis. So the overall prognosis is poor for those patients despite the histologic types. لكن في variation. إذا عم نحكي عن adenocarcinoma and squamous cell carcinoma, it's slightly better than the small cell carcinoma. مثل ما حكينا عن small cell lung cancer, the patient virtually all the patient have metastasis by the time of diagnosis. But surgery is not considered as a curative treatment. انت بحاجة ل systemic chemotherapy and radiotherapy. And despite the good response to the systemic chemotherapy, the overall survival لهدول المرضى ما بيتجاوز 10 شهور. So the median survival for those patients is about 10 months and the cure rate is about 0. وبالتالي هدول المرضى البروجنوسيس عندهم الأسوأ ما بين different histologic types of lung cancer. Paraneoplastic syndrome, it's another manifestation of lung cancer. سمعتوا في paraneoplastic syndrome قبل؟ في حد بيقدر يقول لي إيش يعني؟ تفضل. Yes. Yes, great. So it's like signs and symptoms resulting in clinical change عند المريض ناتج عن إنه tumor بيفرز هرمونات أو بيبتايد into the bloodstream that will result in signs and symptoms عند المريض. Usually those are not the function of this tissue. يعني اللنج بالنورمال ما عم تفرز adrenocorticotropic hormone، لكن lung cancer cells can be able to produce the ACTH and this will result in Cushing syndrome in those patients. So paraneoplastic syndrome is the clinical syndrome that results from the production of peptides and hormones by the tumor cells. Those going to be poured into the bloodstream resulting in systemic signs and symptoms related to the products. Now, the most common tumor that can cause paraneoplastic syndrome is lung cancer. And the most common paraneoplastic syndrome related to lung cancer is hypercalcemia. Most of the histologic types are correlated with hypercalcemia. لكن مين أكثر واحد بيرفع الكالسيوم؟ Squamous cell carcinoma. So squamous cell carcinoma is strongly correlated with the hypercalcemia as a paraneoplastic syndrome. Cushing syndrome, for example, بيجي المريض عنده carcinoid features, moon face, truncal obesity, buffalo hump, hypertension, easily bruising of the skin, and other signs and symptoms, and this is because of the excessive production of the adrenocorticotropic hormone by the tumor cells, and it's mostly correlated with carcinoid and small cell lung cancer. Syndrome of inappropriate antidiuretic hormone, where you have increased production of the antidiuretic hormone, this will result in increase in the fluid retention and dilution of the sodium, فبالتالي بصير عند المريض hyponatremia, most commonly associated with small cell lung cancer. Acromegaly, due to the production of a growth hormone releasing hormone or the growth hormone itself, will result in like features of the acromegaly, enlargement of the body parts and other features, and this is strongly correlated with the small cell lung cancer and carcinoid. لما بنحكي عن strong association أنا ما بقصد إنه other histologic types are not associated with this paraneoplastic syndrome، بس بقصد أقول إنه this is the strongest association. Also, the patient may present with a neuromuscular syndrome like peripheral neuropathy, polymyositis, and mesothelioma syndrome. Hypertrophic pulmonary osteoarthropathy اللي هي نفسها تقريبا الكلابينج finger clubbing can be seen in association with lung cancer, especially squamous cell carcinoma and adenocarcinoma. تعرفوا شو يعني finger clubbing؟ Yes, فإذا بصير الكيرف أكبر، الكيرف للنيلز أكبر، والديستال part of the nerve the nail is wider، فبصير أعرض، يعني الأظافر بتكون أعرض من المنطقة الأمامية والكيرف تبعها أكبر أعلى، فهدول بنسميهم nail clubbing. Now the finger clubbing أو هدول nail clubbing is not specific for lung cancer. It can be seen in any pulmonary or heart disease. And sometimes can be seen in congenital heart diseases, in cystic fibrosis، وأحيانا بيكون هذا idiopathic يعني without cause يعني ما له correlation. So it's just like a fine clue that you need to investigate this patient. إن شاء الله السنة الجاية بس تطلعوا بالintroductory course راح تشوفوا nail clubbing، راح تقرأوا عن differential diagnosis of nail clubbing. The patient may present with coagulation abnormalities like migratory thrombophlebitis, non-bacterial endocarditis, and disseminated intravascular coagulation. The second tumor is carcinoid tumor. Carcinoid tumor is one of the neuroendocrine neoplasms زي ما شفنا التابل بالمحاضرة اللي فاتت، وهذا الtumor is considered like a low-grade neuroendocrine tumor, but it's still malignant. Accounts for about 5% of the lung tumors. As you can see in this figure, the tumor is made of islands or nests of the tumor cells, and the tumor cells are uniform، عم يشبهوا بعض. والcytoplasm تبعهم is like abundant with indistinct cell borders, and the nuclei they look like each other. All of them are finely granular or finely stippled، منقطين، مثل اللي شفناهم حتى في small cell carcinoma. So you have neuroendocrine features, and the tumor cells are arranged in nests. Those tumors are mostly show low mitotic activity if any mitoses are identified. So they account for 5% of the pulmonary tumors. They are considered malignant, however they are low-grade neoplasm. They are made of cells that have the dense core neurosecretory granules in their cytoplasm, so some of them may produce hormonally active polypeptides, resulting in signs and symptoms in the patients, and this is considered rare. It's subclassified into typical and atypical carcinoid, and this will affect the risk for lymph node involvement, distant metastasis, and the treatment. However, both types, typical and atypical, are resectable and curable. So see, the prognosis here is much better than the all histologic types of lung cancer. Sometimes carcinoid can be a clue that this patient have the multiple endocrine neoplasia, min 1 or min 2. And the patient is usually young adult عمره حوالين 40, and the lesion is present centrally in the main bronchi. Sometimes you have peripheral carcinoid, بس الcommon scenario يكون central in one of the main bronchi. About 5 to 15% of the patients, they may have metastasis into the hilar lymph nodes. However, the distant metastasis is considered rare in this type of tumors. As we said, it's considered mainly central، يعني بنشوفه حوالين الهايلم in the main bronchi. However, you may find peripheral carcinoid، وطالما انه ممكن يكون في peripheral، هذا البريفرال غالبا asymptomatic لانه بده وقت طويل حتى يعمل symptoms ويسبب بسبب حجمه او اي شيء بتعلق فيه symptoms عند المريض. The tumor is usually well demarcated, and the tumor may grow in two patterns. عفوا، فكروا انه عندنا واحدة من المين bronchi and you have a growth inside the lumen. ممكن يكون الجروث هذا as a projecting polypoid mass obstructing the lumen, right? So the first growth pattern is as an obstructing polypoid spherical intraluminal mass. Sometimes the growth may happen as a mucosal plaque على surface of the wall, لكن بدل ما يعمل bulging into the lumen بيعمل infiltration into the wall. So the tumor starts as a mucosal plaque penetrating the bronchial wall to fan out into the peribronchial tissue, and this is what we call collar pattern lesion. يعني بيشبه نوع من انواع الازرار بنسميهم الكولر باتن اللي هم الازرار اللي بنحطوا على ابات القمصان المعدنيه. خلينا نطلع على اول فيجر فوق. هون في عندنا one of the this is the gross appearance of like bisected bronchus، واحنا عم نطلع جوا اللومن and the lumen is occupied by polypoid obstructing mass showing the polypoid pattern of growth in these tumors. The other figure shows you نوع الازرار اللي بنحكي عنهم اللي هم الكولر باتن. So افترض معي انه هذا هو الميوكوزال surface. Here is the growth of the tumor, for example, and instead of bulging into the inside of the lumen, the tumor just will infiltrate the wall and fan out to involve the other structures. طلعوا على هذا الفيجر. لو بدنا نعمل هذا يعني نشبه الجروث هذا بهون within the lumen. So you're gonna have a slightly raised area here composed of the tumor, and instead of bulging into the lumen, it's gonna infiltrate downward and invade the underlying structures. فإما to protrude inside the lumen or to infiltrate down into the adjacent structures. Now this figure also shows you an intraluminal polypoid tumor causing obstruction in this main bronchus. قلنا انه بيتقسم ل typical and atypical. الفرق بينهم بالميتوسيس and the presence or absence of necrosis. So the typical carcinoid is composed of those nests or islands of uniform cells that have regular round nucleus with salt and pepper chromatin or finely granular chromatin, with absent usually or rare mitotic figures, and there is no necrosis. While in atypical carcinoid there is higher mitosis. يعني بتلاقي عندك mitosis ممكن تشوف necrosis. Why it's important? Because atypical carcinoid is associated with higher incidence of lymph node involvement and maybe distant metastasis, and this is because it has p53 mutation in about 20 to 40% of cases. Again, this figure shows you the carcinoid tumor, the typical carcinoid. You have an island or nest of uniform cells that have finely granular chromatin, abundant cytoplasm in distinct cell border, and they are arranged in nest-like structures without lumen in the middle. إذا كانت typical ما رح تشوف أي mitosis. إذا كانت atypical ممكن تشوف scattered mitosis in this lesion. إذا tumor عمل intraluminal growth بتتوقع أنه يجي المريض بsymptoms related to the obstruction of the lumen, and this can include cough, hemoptysis, which means coughing blood, recurrent bronchial and pulmonary infections. While peripheral tumors may stay silent for long period of time وأحيانا نكتشفهم incidentally. بعمل chest x-ray بتلاقي عندك radio opacity فبتفكر إنه هذا المريض ممكن يكون في عنده carcinoid tumor أو أي شيء، فبتاخذ منه biopsy ممكن تكون pneumonia حتى، فبتعرف إنه عنده carcinoid tumor. Rarely this tumor may produce serotonin يعني hormones, and this will result in paraneoplastic syndrome. Here it's called carcinoid syndrome, where the patient will present with intermittent attacks of diarrhea, flushing, and cyanosis. In terms of a prognosis, those patients do much better than the patients with lung cancer. So the 5-year and 10-year survival rate للtypical carcinoid أكثر من 85%. So see how it's good. While on the other hand, the atypical carcinoid في أسوأ حالاته the 5-year survival rate is about 56% and the 10-year survival rate is about 35%, still better than the all histologic types of lung cancer. The third type of tumors in this lecture is malignant mesothelioma. Malignant mesothelioma correlates with the mesothelial cells. وين بنشوفهم؟ Yes. وين؟ peritoneal, yes. بلورا and دكتورين اللي هناك ممكن تقعدوا بعيد عن بعض. يعني this is annoying. انتوا الوحيدين بتحركوا بالقاعة. اوكي. طيب. Mesothelial cells هم عبارة عن خلايا. They line the pericardial cavity, the pleural cavity, and peritoneal cavity. So we are talking about malignant cells that recapitulate those cells. Now, malignant mesothelioma is considered as a rare cancer. So it's a rare type of tumors that made of mesothelial cells that usually line the parietal and visceral pleura and less commonly the peritoneum and the pericardium. درستوا محاضرة النيموكونيوسيس؟ اوكي. في البارت تبع الاسبستوز اكيد قرأتوا انه it's correlated with the development of mesothelioma، وقرأنا انه الريسك بالنسبة للأسبستوز is not limited to the workplace exposure، يعني مش بس اللي بيشتغلوا في هاي الصناعة أو في هاي المناجم، لا كمان الناس اللي بتعرضوا للأسبستوز بسبب إنهم ساكنين في أماكن فيها ماتيريالز قديمة في الدهانات أو الانسوليشن، وكمان الناس اللي هم الهاوس هولد كونتاكت لشخص بيشتغل بالأسبستوز بروح كل يوم ملابسه متسخة بالدست تبع الأسبستوز. إذا the risk to develop cancer is not limited only to the people who work with asbestos, but also people living in proximity to the asbestos factories, and also it can be related to the exposure outside the workplace. The other thing طبعا هو highly correlated to the asbestos exposure، يعني غالبا المريض إذا عنده ميزوثيليوما فهو متعرض سابقا للأسبستوز. النقطة الثانية إنه for the patient to develop mesothelioma الأسبستوز worker هذا بده 25 ل 40 سنة، ففي عنا long latent period. فلو افترضنا إنه هذا المريض بدخن صح عنده risk for lung cancer، إذا ممكن يموت من اللung cancer قبل ما يصير في عنده mesothelioma. Because if you remember from the previous lecture, the synergy between the effect of the carcinogens and the tobacco smoke and the asbestos fibers will increase risk for developing lung cancer 55 folds than the general population. بينما بالنسبة للميزوثيليوما it's affected only by the asbestos exposure. إذا smoking does not increase the risk for mesothelioma, just increases the risk for lung cancer. Again, إذا في عنا long latent period للأسبستوس exposure to cause mesothelioma, and tobacco smoking has nothing to do with the increased risk for development of malignant mesothelioma, while patients who work with the asbestos and smoke, they have increased risk to develop lung cancer. Okay? Now once inhaled هدول الأسبستوس fibers رح يضلوا بالbody for life, and this will induce the reaction over years, and this may increase the risk to develop mesothelioma and to develop lung cancer إذا المريض بدخن. So the lifetime risk after the exposure does not diminish over time. يعني بما إنه الفايبرز ضلت موجودة في الديستال ايرويز ضلت موجودة مكانها، فإذا الريسك ما رح يقل بعد وقت من توقف عمل المريض في هاي الصناعة أو الإكسبوجر. As any patient working with the asbestos، واحدة من المانيفستيشنز الموجودة في المحاضرة تبعت النيموكونيوسيس إنه يكون عنده extensive pleural fibrosis and plaques. So patients إذا طلعنا grossly رح نلاقي extensive fibrosis involving the pleura, and usually the lesions are localized, but they may spread widely and they may cause seeding into the pleural surfaces. However, the distant metastasis is considered rare with malignant mesothelioma. Usually those tumors are described as enshithing، يعني بيغلفوا اللنج من برا. فجروسلي على الأوتوبسي بالعين المجردة بتلاقي اللنج مغلفة بلاير لونها أبيض أو يلو مثل هاي اللاير، and this indicates إنه هذا هو tumor اللي occupying the pleural surface enshithing the lung. So this figure shows you the gross appearance of mesothelioma, where you have a tumor that ensheth the affected lung by a layer of yellow-white firm and variably gelatinous tumor that will cause obliteration of the pleural surface. Just to remind you with the normal histology of the mesothelial cells, so the mesothelial cells are biphasic. They may grow into like columnar or cuboidal cells or حتى flattened cells lining the surface of the pleura, pericardium and peritoneal cavity, and also they develop this fibrous layer just beneath the epithelium. So a tumor هذا is reflected also على الميزوثيليوما. So it has one of the three morphologic patterns. It could be epithelial like cuboidal cells lining cystic-like spaces. And this is one of the main differential diagnoses of pulmonary adenocarcinoma. لأنه عندك malignant tumor growing as glands أو cystic-like spaces. فرح تفكر إنه a differential diagnosis عندي includes pulmonary adenocarcinoma, and you need to use immunostains زي TTF1 اللي درسناه بالمحاضرة اللي فاتت, and you may use calretinin and WT1 as markers of mesothelial differentiation. The tumor also can be growing as a spindle cells, and this is called sarcomatous. So الشكل الثاني للgrowth ممكن يكون sarcomatous. And also the tumor can be biphasic, يعني فيه الابيثelial component اللي بيشبه البulmonary adenocarcinoma, and also it may show the spindle cell proliferation. This figure shows you an invasive mesothelioma or malignant mesothelioma. This background tissue shows dysplasia, and here is the epithelial proliferation. إذا دققنا رح نلاقيه عامل دوائر هيك و cystic-like spaces عندها lumen or tubular structure. So this is the epithelial pattern of malignant mesothelioma. If I want to confirm that, بطلب TTF1 immunostain بطلع negative, بعمل calretinin and WT1 بطلع positive, indicating that those cells are mesothelial. إذا بترجعوا على الكتاب رح تلاقوا تفاصيل أكتر بكتير, بس أنا حبيت إنه just to touch base على هدول tumors بدون details. So now let's try to solve some cases. Please read the stem and try to collect the clues. Okay, let's read the case. We have a 69 years old gentleman smoker presented with cough, 7 kilogram weight loss over the past 4 months. Physical exam shows finger clubbing. He is febrile. The chest X-ray shows no hilar adenopathy, but there is cavitation with a 3 centimeter lesion near the right hilum. Labs show elevated serum calcium. Bronchoscopy shows lesion occluding the right main bronchus. A surgical procedure with a curative intent is attempted. Which of the following neoplasm is most likely to be present in this patient? طبعا ما رح يجيكم كيس يعني ولا بالحياة نادر ولا بالامتحانات فيها كل هدول الكلوز. So هذا just revision عشان يعني نعرف قديش بنقدر نستفيد من الستم للسؤال. So your first clue in this case is قبل. أولا هو old age, male, وsmoker, and then the symptoms. طيب, what do we learn from these symptoms? يعني عنده كف 7 kilogram weight loss. What does that mean? مو شرط. قرأنا نفس هاي المعلومة بالrestrictive lung diseases, weight loss and cough, shortness of breath. So this indicates that we have a chronic process. بس يعني it can be fine clue مع باقي الستم ولأنه بمحاضرة lung cancer, بس in general this does not for sure indicate إنه المريض عنده chronic إنه عنده lung cancer. The chronic processes كمان تعمل weight loss. طيب next is a clue. Finger clubbing. بس هذا مش strong clue صح؟ احنا قاعدين عم نجمع فيهم بس ممكن ينشاف حتى بشخص نورمال ما عنده أي مرض. then قبل he is afebrile ما عنده حرارة، شو بنستفيد؟ بدي أقول لك إنه ما في infection، ليش؟ لأنه lesion is causing cavitation and your number one differential diagnosis في lesion عامل cavitation إيش؟ tuberculosis أو infection سواء كان fungal أو bacterial infection. The other clue بقول لك ما في hilar lymphadenopathy، بده يدل لك كمان إنه ما في infection. Like two things to point إنه ما عنده infection. Then we have a 3 centimeter lesion near the right hilum, so we have centrally located mass. عندنا mass lesion, certain growth. Okay. And then the lab shows elevated serum calcium. وين درسنا ال elevated serum calcium قبل؟ paraneoplastic and also إشي من restrictive lung diseases بيعمل hypercalcemia لأنه الماكروفاجز بعتوا ال 1 alpha hydroxylase, one of the granulomatous diseases, sarcoidosis. Okay. I mean this case في هاي المحاضرة بكل هدول الكلوز سهلة، بس إذا أنت عم تستخدم هاي المعلومات حتى تميز obstructive من restrictive من tuberculosis من pulmonary vascular diseases أو tumors, you need to use every single clue عشان تعرف تحل. Okay. And then we have a lesion that occupies the right main bronchus centrally located, and then the surgical procedure with a curative intent. So هم ما شالوا هذا التيومر لأنه عامل obstruction as a palliative therapy، يعني لتخفيف الأعراض عن المريض وليس لعلاجه. لا، الهدف هو to cure the patient. Sometimes we do palliative therapies، يعني عارفين إنه هذا المريض يعني is dying anyway، لكن في عنده symptoms we need to relieve it. الهدف من هاي العملية ما كان هيك، الهدف كان لعلاج المريض to cure the patient. So this indicates that this type of a tumor have a better prognosis or slightly better prognosis if compared with other types. So your best diagnosis for this patient is لا. Oh my god. Oh my god. هذاك صعب. تحبوا تروحوا تدرسوا وترجعوا ايش في؟ كل هدول الكلوز. Should be squamous cell carcinoma. Okay. Next case. اصحوا. إذا ضليتوا نايمين تاخذوا الكيسز وتدرسوهم لحالكم. Okay. Okay, let's read the case. A 57-year-old lady presented with a chronic non-productive cough for 4 months, along with weight loss and 7 kilogram loss of appetite. She does not smoke. On physical exam, no remarkable findings. Her chest X-ray shows a right peripheral subpleural mass. FNA biopsy is performed, and she undergoes a right lower lobectomy. Under the microscope, she has a proliferation of atypical cells with a glandular differentiation. Which of the following neoplasm did she most likely have? So let's try to collect the clues. Your first clue in this case is the age. Then هو أي نوع من الhistologic type much more common in females? The most common type in females? Adenocarcinoma. Okay, good. And then the symptoms that indicate that we have like a chronic process, correct? And then هم كل الsymptoms هدول. مين most common histologic type in non-smokers أو never smokers? Adenocarcinoma. Good. And then She has a peripherally located subpleural mass, so the lesion is peripherally located. This is a fine clue of certain types of histologic types of tumor that tend to happen at the periphery of the lung. And they did right lower lobectomy, so they wish to cure the patient. شالوا اللوب كلها دليل إنهم بدهم يعالجوها للشفاء وليس لتخفيف الأعراض. Under the microscope, the tumor is made of proliferating cells with a glandular differentiation. So your best diagnosis for this patient is A, adenocarcinoma. Good. Right, next case. Please read the stem and try to collect the clues. Okay, we have a 48 years old gentleman developed truncal obesity, back pain, skin that bruises easily over the past 8 months. On physical exam, he is afebrile, his blood pressure is about 160 over 95 millimeter of mercury, يعني مرتفع ضغطه شوي. Chest X-ray shows an ill-defined 5 centimeter mass involving the left hilum of the lung. Cytologic examination of the bronchial washing from the bronchoscopy shows round epithelial cells that have the appearance of lymphocytes, but they are larger. The patient is told that although his disease is apparently localized to one side of the chest cavity, surgical treatment is unlikely to be curative. He is also advised to stop smoking. Which of the following neoplasm most likely to be present in this patient? So let's try to collect the clue. Your first clue in this case is هلا هذا المريض عنده carcinoid features صح؟ شو هم الcarcinoid features الموجودين بالستم؟ truncal obesity بس easy bruising hypertension and back pain. كل هدول can be seen in a patient with increased production of the ACTH. Okay, and the symptoms are chronic 8 months. ممكن يكون في عنده Cushing أو Cushing-like disease، يعني ممكن يكون Cushing فعلا أو carcinoid features related to the production of hormones from a tumor, for example. And then the next clue. So the patient is afebrile and he has elevated blood pressure. They found a mass, 5 centimeter mass موجودة centrally located, and the cytologic exam shows that we have round epithelial cells. So it's an epithelial tumor basically, مش lymphatic مثلا. لكن الخلايا هذول حجمهم قد الليمفوسايتس أو بيشبهوا الليمفوسايتس لكن أكبر منهم بشوي. So we have a small size. Remember the definition of small size? The size of 2 resting lymphocytes. So we have a small size tumor. So we are talking about small cell neoplasm. And the patient is told that although the disease is localized, لكن ما رح يعملوا له surgical treatment to cure the patient. So this means that the prognosis is poor. This is bad. Okay, so we have carcinoma. So we have a small cell carcinoma. And then they advised him to stop smoking due to the strong association of this type of tumors with tobacco smoking. So your best diagnosis for this patient is small cell carcinoma. Correct. Last case. Okay. ACTH. مش antidiuretic hormone. ACTH. Okay. Please read the stem and try to collect the clues. Okay, we have a 55 lady presented with cough, pleuritic chest pain for 3 weeks. The patient is afebrile and she have crackles over that are audible over the left lower lung on auscultation. The chest X-ray shows ill-defined area of opacifications in the left lower lobe. After 1 month of antibiotic therapy, her condition did not improve. يعني هم فكروا إنه هذا lung infection, right? كان في عندها radio opacity منطقة بيضاء فكروها infection. And the CT guided needle biopsy is performed and the specimen is shown in the figure. Which of the following neoplasm is most likely to be present in this patient? So let's try to collect the clues. Your first clue in this case is okay, so we have good age for chronic processes and it's a female. The most common tumor in females is adenocarcinoma. And then you have signs and symptoms for 3 weeks. It's like a subacute, ولا acute, ولا chronic, يعني evolving process. The patient is afebrile, the same clue, but the problem is seen in the left lower lung, right? And when they did the chest X-ray, it's confirmed to be in the left lower lung because they find an ill-defined area of opacification, يعني بياض, يعني radio opacity. فهذا دللهم انه هذا ممكن يكون انفكشن نمونيا، فبدهم يعالجوا هاي النمونيا او الاريا اوف كونسوليديشن، اعطوها انتيبيوتيك، شهر انتيبيوتيك ما تحسنت. This is not uncommon scenario، هذا بصير بشكل متكرر، فبيروحوا بياخذوا بايوبسي. اخذوا بايوبسي لقوا انه ما في عندنا لانج انفكشن، بالعكس لقوا هذا الابيرنس الموجود هون. في حدا بيقدر يقول لنا شو موجود عندنا histologic findings in this slide؟ تفضلي. في عنا atypia. إذا في عنا epithelial cells right here that shows atypia in the form of hyperchromasia. See how dark the nucleus, and also pleomorphism, في variation in the nuclear size and shape, and some of the cells are stratified. What else? ما في invasion. We have a preserved alveolar wall architecture, and the basement membrane is still preserved. And there is no stromal invasion or dysplasia. So we have some form of in situ lesion with dysplasia. Ignore الأوبشنز اللي هون. لو كان في عندي option لأتيبيكال adenomatous hyperplasia أو adenocarcinoma in situ. Can you decide? لا. Depends on the size. The size of the lesion is not provided here. طبعا أنا بحكي بناء على المعلومات المعطاة لكم سابقا. هلا as a pathologist you must say إنه هاي adenocarcinoma in situ. بس بناء على المعلومات اللي أعطيتكم إياها أنا قلت لكم إنه الأتيبيكال adenomatous hyperplasia هي شوية أتيبيا وكل شيء preserved لليجن well demarcated نص سنتي. بينما إذا الليجن كان أكبر بتصير adenocarcinoma in situ with more features of dysplasia. بالنسبة لي أنا هاي dysplasia is enough to call adenocarcinoma in situ. لكن ممكن تكون الحالة معقدة أكثر وأعطيك سايز وأقول لك إيش هو diagnosis. So your best diagnosis for this case is adenocarcinoma in situ. Perfect. طيب يعطيكم العافية وإن شاء الله بشوفكم بعد الامتحان بالفصل الجاي بالCNS. أنا رح أدرسكم البرين تيومرز وأعتقد البريست كانسر في الUGS. يعطيكم العافية.